and mechanical modifications of the red cells that can worsen into life-threatening complications of malaria. While the vast majority of severe malaria and related mortality are caused by P. falciparum infection, complications can occur in non-falciparum infections as well. In recent years, several cases of severe infection and even deaths have been reported following infections with P. vivax and P. knowlesi infections. Several pathophysiological factors such as the parasite biomass, malaria toxins, and inflammatory response, cytoadherence, resetting and sequestration. Falciparum infection compared to non-falciparum infections. As a result, except for severe anemia, complications such as cerebral malaria, hypoglycemia, metabolic acidosis, renal failure. Although death due to splenic rupture has been reported in patients with non-P. falciparum malaria, severe malaria manifests as cerebral malaria, severe anemia, respiratory symptoms, and renal failure. In children, malaria has a shorter course, often rapidly progressing to severe malaria. Children are more likely to present with hypoglycemia, seizures, severe anemia, and sudden death, but they are much less likely to develop renal failure, pulmonary edema, or jaundice. 1. Cerebral malaria. This feature is almost always caused by P. falciparum infection. Anemia may be secondary to erythrocyte infection and a loss of infected RBCs. In addition, uninfected RBCs are inappropriately cleared, and bone marrow suppression may be involved. 3. Renal failure. Renal failure is typically reversible, although supportive dialysis is often needed until kidney function recovers. In rare cases, chronic P. malariae infection results in nephrotic syndrome. 4. Respiratory symptoms. Patients with malaria may develop metabolic acidosis and associated respiratory distress. In addition, pulmonary edema can occur. Signs of malarial hyperpneic syndrome include alar flaring, chest retraction, intercostals or subcostal, use of accessory muscles for respiration, or abnormally deep breathing. It cannot be used by women who are pregnant or breastfeeding a small child. Malaron should be started for prophylaxis 1 to 2 days before potential malaria exposure. It is taken daily, and side effects may include increased sun sensitivity, stomach upset, or vaginal yeast infections in women. Doxycycline should be started for prophylaxis 1 to 2 days before potential exposure. Is taken daily, and must be continued for 4 weeks after your trip. Lariam, mefloquine. This drug is considered safe during pregnancy, but it's not compatible with certain psychiatric seizure. Deciding on a treatment plan. Which drug or combination of drugs you take to treat malaria, and the length of your treatment, will be based on several factors. Geographic location of infection. Malaria parasites commonly become resistant to drugs, with different patterns of drug resistance seen in different areas of the world. Arelin, chloroquine, and Plaquenil, hydroxychloroquine. Arelin and Plaquenil are the first-line treatment for uncomplicated malaria without known drug resistance from Central America west of the Primaquine. This drug is given to people with malaria caused by P. vivax or P. ovale to kill immature parasites in their liver. Primaquine is not an option for people with G6PD deficiency. Malaron, atovarone and proguanil. This drug combination can cause stomach upset and should be taken with food or milk. Doxycycline, tetracycline, and clindamycin. Doxycycline, tetracycline, artesunate. This drug is given by IV to people with severe malaria who cannot tolerate Quinadex. Medical providers must contact the Centers for Disease Control and Prevention (CDC) to obtain this drug.